You're listening to He Said, a Cardiology Board Review Series. No fluff, just facts.
This episode is about sinus node dysfunction. We'll talk about a systematic approach to sinoatrial exit block, sinus pause, and sinus arrest. We'll go over common etiologies, and then we'll touch upon sinus bradycardia, sick sinus syndrome, and tachybrady syndrome. Let's start with a systematic approach to sinoatrial exit block, sinus pause, and sinus arrest. The sinoatrial node, or SA node, consists of a central core of pacemaking cells, P cells, that produces sinus impulses, and a surrounding layer of transitional cells, T cells, that transmit the sinus impulses out into the rest of the right atrium. Sinus node dysfunction can result from failure of the P cells to produce an impulse, leading to sinus pauses and sinus arrest, or failure of the T cells to transmit the impulse, leading to sinoatrial exit block. While the types of AV node blocks are widely taught, the types of sinoatrial blocks are less well known but follow a very similar paradigm. While first-degree and third-degree sinoatrial blocks cannot be diagnosed on surface ECG, second-degree sinoatrial blocks can be diagnosed on surface ECG. Let's start with sinoatrial exit block first degree. In normal SA conduction, atrial activation and depolarization, formation of the P wave, occurs almost immediately after the discharge of the impulse in a sinoatrial node. In first-degree SA block, there is prolongation in the interval from the time of discharge of the impulse in the sinoatrial node to the onset of atrial depolarization in the atrium. This means that the P wave occurs at a consistently fixed later time. However, the discharge of the impulse in a sinoatrial node is too small to be picked up on surface ECG, so it is impossible to discern first-degree sinoatrial block on surface ECG. The rhythm remains regular and intervals remain normal. Next, we have sinoatrial exit block second degree type 1, also known as sinoatrial Wenckebach. In second degree type 1 sinoatrial block, also known as sinoatrial Wenckebach, the delay in the time from the discharge of the impulse in the SA node to the time of the atrial depolarization increases gradually until one impulse is completely blocked, resulting in no P wave. The key counterintuitive concept is that the gradually lengthening transmission interval actually pushes successive P waves closer together, making the P wave closer to the corresponding QRS complexes. So the PP gradually shortens prior to the drop P wave and resumes from the duration of the original P to P interval again. Note that in second degree type 1 sinoatrial block, the PP interval at the pause does not exceed twice the duration of the shortest PP interval. Also note that this pattern, sinoatrial Wenckebach, is often incorrectly mistaken for sinus arrhythmia. Next, we have sinoatrial exit block second degree type 2. In second degree type 2 SA block, the sinoatrial impulses are blocked sporadically. There's no prolongation of the duration of time from the discharge of the impulse in the SA node to the time of atrial depolarization. Therefore, the pause resulting from the blocked sinus impulse will be wrapped within a PP interval that is a whole number multiple of the normal PP interval. There's no clustering of P QRS complexes. The pause surrounding the drop P wave can be 2 times the duration of the preceding PP interval, or 3 times the duration of preceding interval, or a mix of whole number intervals. Then we have sinoatrial exit block third degree. In third degree sinoatrial block, no impulses whatsoever are conducted from the SA node to the atrium. Therefore, there will be no depolarization of atrium and thus no P waves. Nevertheless, mortality in this rhythm remains very low because a latent pacemaker will usually take over, either from the junctional area or from the His-Purkinje network. Because the discharge of the impulse in a sinoatrial node is too small to be picked up on surface ECG, it is not possible to diagnose third-degree SA block on surface ECG. So those are the sinoatrial exit blocks. Now let's talk about sinoatrial pause and sinoatrial arrest, which are not the same thing. Sinoatrial arrest is when the SA node does not discharge an impulse for at least 2 seconds. Sinoatrial pulse is when the SA node does not discharge an impulse for less than 2 seconds. In either case, the pause is not a whole number multiple of the preceding PP intervals. When there's no SA node discharge, the usual atrial P wave will not occur. Usually, an escape pacemaker will take over. Cells around the AB node can generate an escape rhythm at 40 beats per minute within a normal QRS complex, or cells in the His-Purkinje network can generate an escape rhythm at 20 to 40 beats per minute with a wide QRS complex. In the former, where cells around the AB node generating an escape rhythm, if a P wave is visible, it will be inverted in lead 2 due to the reverse direction of atrial activation and is usually located after the QRS complex. There's also a third possibility where specific clusters of atrial myocardium generate an escape rhythm around 60 beats per minute. These will generate P waves before the QRS complex, but they will be morphologically different from the sinus P wave. Lastly, if none of the 3 latent pacemakers awakens, then asystole occurs. But persistent asystole is rare. Latent pacemakers almost always take over to salvage the rhythm. Then we also have non-conducted premature atrial contraction. Be on the lookout for an ectopic atrial beat that is non-conducted. This is actually a common phenomenon. This is characterized by a P wave that occurs during the repolarization of the ventricles, altering the morphology of the T wave. The P wave is not conducted, resulting in a pause that is of a random duration. This is a compensatory pause. The PP interval of the pause will not be a multiple of the preceding PP intervals, unlike second-degree SA block. There will be a partially hidden P wave, unlike in sinoatrial arrest and sinoatrial pause. There will be no early QRS complex, unlike in second-degree SA block with a junctional escape beat. I know that was complicated, but I hope that explanation allows you to understand the subtle differences between sinoatrial arrest, sinoatrial pause, non-conductive premature atrial contraction, and the first, second, and third degrees of sinoatrial exit block. So, when can you use temporary pacing in these rhythms? According to the 2018 ACC/AHA HRS guideline on the evaluation and management of patients with bradycardia and cardiac conduction delay, in patients with persistent hemodynamically unstable sinus node disease refractory to medical therapy, temporary transvenous pacing is reasonable to increase heart rate and improve symptoms until a permanent pacemaker is placed or the bradycardia resolves. That's a Class 2A recommendation. In patients with sinus node dysfunction with severe symptoms or hemodynamic compromise, temporary transvenous pacing may be considered to increase heart rate and improve symptoms until a temporary transvenous or permanent pacemaker is placed or the bradycardia resolves, Class 2B. In patients with sinus node dysfunction with minimal and/or infrequent symptoms without hemodynamic compromise, temporary transcutaneous or transvenous pacing should not be performed, Class 3 harm. When can you use permanent pacing? According to the 2018 bradycardia guidelines, in patients with symptoms that are directly attributable to sinus node dysfunction, permanent pacing is indicated to increase heart rate and improve symptoms. That's a Class 1 recommendation. In patients who develop symptomatic sinus bradycardia as a consequence of guideline-directed medical therapy, for which there is no alternative treatment and continued treatment is clinically necessary, permanent pacing is recommended to increase heart rate and improve symptoms, Class 1. In patients with symptomatic chronotropic incompetence, permanent pacing with rate-responsive programming is reasonable to increase exertional heart rates and improve symptoms, Class 2A. In patients with symptoms that are likely attributable to sinus node dysfunction, a trial of oral theophylline may be considered to increase heart rate, improve symptoms, and help determine the potential effects of permanent pacing, Class 2B. It is quite frequent that we get consults requesting pacemaker replacement in patients with sinus pauses that are related to sleep, elevated parasympathetic tone, or non-specific symptoms. Fortunately, the 2018 AHA-ACC HRS guideline on the evaluation and management of patients with bradycardia and cardiac conduction delay is very clear on this. In asymptomatic individuals with sinus bradycardia or sinus pauses that are secondary to physiologically elevated parasympathetic tone, permanent pacing should not be performed. Class 3, harm. In patients with sleep-related sinus bradycardia or transient sinus pauses occurring during sleep, permanent pacing should not be performed unless other indications for pacing are present. Class 3, harm. In patients with asymptomatic sinus node dysfunction, or in those in whom the symptoms have been documented to occur in the absence of bradycardia or chronotropic incompetence, permanent pacing should not be performed. Class 3, harm. Now let's go over the etiologies. Sinus node dysfunction occurs from reversible processes or non-reversible processes, such as degenerative fibrosis of the sinus node and sinoatrial area. A thorough review of triggers should be undertaken. Sinus node dysfunction could be idiopathic, as I mentioned, from degeneration or normal aging. It could be from acute myocardial ischemia or infarction, especially if it is an RCA occlusion or a dominant left circumflex occlusion. You can have this as a result of the gyrus basal reflex. Also look across medications. Is the patient on a beta blocker, calcium channel blocker, digitalis, class 1 or class 3 antiarrhythmic, or clonidine? It could be a vagally mediated bradyarrhythmia. Look for a highly conditioned state as in athletes, sleep, especially in elderly individuals, vomiting or retching, suctioning or intubation, urination, defecation, coughing or swallowing, CNS trauma, or high intracranial pressure. The most common intrinsic cause of inappropriate or pathologic sinus bradycardia is age-related myocardial fibrosis in the vicinity of the sinus node, and the most common extrinsic cause of sinus bradycardia is medication. Interestingly, the 2018 guidelines, unlike the 2012 guidelines, dropped the 3-second pause criterion for indicating pacing with a pacemaker. They also dropped the heart rate criterion for pacing. The 2018 guidelines say that permanent pacemaking, is indicated based on the establishment of an irreversible cause of sinus node dysfunction and symptoms. If symptomatic sinus node dysfunction at rest, that's a class 1 indication to place a pacemaker. If symptomatic sinus node dysfunction at rest and necessary drug therapy is required, that slows heart rate, that's also a class 1 indication to place a pacemaker. If symptomatic chronotropic incompetence, that's a class 2A indication for a pacemaker. And if symptomatic tachybrady syndrome, that's a class 2A indication. The most commonly accepted definition for chronotropic incompetence includes a failure to reach 80% of maximum predicted heart rate after subtracting the resting heart rate from both the numerator and denominator with exercise. Obesity, deconditioning, and baroreceptor response would not be expected to cause inadequate heart rate response to exercise. Timolol eye drops can produce systemic effects, including bradyarrhythmias that mimic sinus node dysfunction. Both paroxetine and timolol are metabolized by cytochrome P452D6, and when co-administered can increase the concentration of the other drug. Drugs causing bradycardia should be discontinued before making a diagnosis of sinus node dysfunction. Now let's focus a bit on sinus bradycardia. Other than beta blockers, medications that can cause sinus bradycardia are calcium channel blockers, amiodarone, lithium, and digoxin, among others. Other than athletes, increased vagal tone states that can cause sinus bradycardia are sleep and ischemic myocardium. Other than myxedema and hypothermia, metabolic causes of sinus bradycardia are hypoglycemia, sepsis, and hypoxia. Obstructive sleep apnea and increased intracranial pressure also cause sinus bradycardia. Atenolol is a water-soluble beta blocker and accumulates in renal failure and may cause significant sinus node dysfunction with severe bradycardia. Therefore, you should consider discontinuing atenolol in AKI. What is the treatment? Well, it depends on several things. Patients presenting with symptomatic sinus node dysfunction, secondary to reversible cause should first be managed by directing the therapy at eliminating or mitigating the offending condition. This is a class 1 recommendation. Symptomatic sinus bradycardia, let me rephrase that. Sinus bradycardia itself does not need to be treated unless symptomatic, and you can attribute the symptoms specifically to the sinus bradycardia. The 2018 ACC-AHA HRS guideline on evaluation and management of bradycardia and cardiac conduction delay allows for the use of atropine, isoproterenol, dopamine, dobutamine, or epinephrine. In patients with SND associated with symptoms or hemodynamic compromise, they say that atropine is reasonable to increase sinus heart rate. That's a class 2A recommendation. In patients with sinus node dysfunction associated with symptoms or hemodynamic compromise who are at low likelihood for coronary ischemia, isoproterenol, dopamine, dobutamine, or epinephrine may be considered to increase heart rate and improve symptoms. Class 2B. How much should you give? These are the doses in the guidelines. The atropine injection is 0.5 to 1 milligrams IV. It may be repeated every 3 to 5 minutes to a maximum dose of 3 milligrams. Dopamine drip is 5 to 20 micrograms per kg per minute as a drip, starting at 5 micrograms per kg per minute and increasing by 5 micrograms per kg per minute every 2 minutes. Dosages of dopamine exceeding 20 micrograms per kg per minute may result in vasoconstriction or arrhythmias and are not recommended. Epinephrine drip is 2 to 10 micrograms per minute IV or 0.1 to 0.5 micrograms per kg per minute IV titrated to desired effect. Isoproterenol drip is 20 to 60 micrograms IV bolus, followed by 10 to 20 micrograms or infusion of 1 to 20 micrograms per minute based on heart rate response. Be sure to monitor for potential development of ischemic chest pain. Note that in transplant patients, atropine should not be given because their vagus nerve is not connected. Instead, you can give aminophylline or theophylline. The 2018 bradycardia guidelines say, in patients who have undergone heart transplant without evidence for autonomic reinnervation, atropine should not be used to treat sinus bradycardia, class 3 harm. In post-heart transplant patients, aminophylline or theophylline is reasonable to increase heart rate if clinically indicated, class 2A. The 2018 bradycardia guidelines do allow for the use of reversal agents in medication-related bradycardia. They say, in patients with bradycardia associated with symptoms or hemodynamic compromise because of calcium channel blocker overdose, intravenous calcium is reasonable to increase heart rate and improve symptoms. That's a class 2A recommendation. The dose of 10% calcium chloride is 1 to 2 grams IV every 10 to 20 minutes, or an infusion of 0.2 to 0.4 mils per kg per hour. The dose of 10% calcium gluconate is 3 to 6 grams IV every 10 to 20 minutes, or an infusion at 0.6 to 1.2 mils per kg per hour. In patients with bradycardia associated with symptoms or hemodynamic compromise because of beta blocker or calcium channel blocker overdose, glucagon is reasonable to increase heart rate and improve symptoms. That's a class 2A recommendation. The dose of glucagon is 3 to 10 milligrams IV with infusion of 3 to 5 mg per hour. In patients with bradycardia associated with symptoms or hemodynamic compromise because of beta blocker or calcium channel blocker overdose, high-dose insulin therapy is reasonable to increase heart rate and improve symptoms. That's a class 2A recommendation. The dose of insulin is IV bolus of 1 unit per kg followed by an infusion of 0.5 units per kg per hour. Now we'll move on to sick sinus syndrome. 3 ways where bradyarrhythmias of decreased automaticity can come about are physiologic slowing of sinus rate, physiologic or pathologic enhancement of parasympathetic activity, and pathologic pacemaker failure. This latter one is sick sinus syndrome. Sick sinus syndrome should really be renamed sick pacemaker syndrome because it's more than the sinus node that is not working. The entire conduction system is involved. If it was just a sinus node problem, an escape beat, such as a junctional escape beat, would jump in and cause a beat. can take over. Features of sick sinus syndrome are bradyarrhythmias occurring at rest, inability to appropriately increase the pacemaking rate with increased sympathetic activity, no escape rhythm when the sinus rate slows, and sensitivity to suppression of impulse formation by various drugs or during reentrant tachyarrhythmia. The sick sinus syndrome is part of tachybrady syndrome. The tachy period is usually AFib. If tachycardia is present together with bradycardia, it is called tachybrady syndrome. The bradycardia component could be sinus arrest, sinus pause, sinoatrial exit block, or sinus bradycardia. The tachycardia component could be atrial fibrillation, atrial flutter, atrial tachycardia, AVRT, or AVNRT. According to the 2018 bradycardia guidelines, for patients with tachybrady syndrome and symptoms attributable to bradycardia, permanent pacing is reasonable to increase heart rate and reduce symptoms attributable to hypoperfusion. Class 2A. In patients with permanent atrial fibrillation and symptomatic bradycardia, permanent pacing is recommended. Class 1. That's all for this episode on sinus node dysfunction.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.